All right, guys, we're back with head, neck, and spine injuries, and now we're going to talk about some of the specific injuries. Some of them we actually have already talked about, so again, we'll try not to go too deep into this. Comminuted fractures, again, that's when you got multiple skull fragments, and usually there's severe brain trauma up underneath that. So if you're feeling little bits and pieces while you're doing your exam and you're feeling things, more than likely they've got a major trouble down there. Your basilar skull fractures, that's the base of it. They can produce either raccoon eyes or battle signs. The thing I'm going to caution you about, both of these take a couple of hours to form. So if you're seeing these, that means it's already happened. Again, this is an example of battle signs. And again, you're bruising around here. The bruising around the eyes it only takes about 30-45 minutes actually to start those, but it's usually a pretty good sign. Remember, the basal fracture can tear the dura mater and it can open the brain, the body surfaces, and remember that's a route for infection. The halo sign, that's when you put a drop of blood on a gauze pad, and then the cerebral spinal fluid goes to the outside of the blood. Bullet entrance wounds usually have small comminuted fractures with those, and again, it usually seriously damages the inside of the contents. And so again, knowing the angle, the ballistics of the bullet, again, usually devastating damage to the brain, and it very rarely is survivable, by the way. So yeah, the headshots do kill. And again, an impaled object, again, we don't want to cause hemorrhage or injury, immobilize it where it's in place. Your facial injuries, again, these guys can cause both airway and physical appearance problems, and the blood can then accumulate in the airway, especially when we're talking about the different facial fractures. Again, you can lose mandible dislocation, a mandibular fracture. All of these things can cause problems. Your Lefort fractures, I would know my 3 Lefort fractures and where those cuts are there. The Lefort's 1, by the way, it's got a slightly unstable maxilla. Or Lefort 2 is both the maxilla and the nasal bones. And number 3, that's the extensive one, the zygoma, the metal bones. So again, a Lefort 1, a Lefort 2, and then Lefort 3s they're huge. Boxers a lot of times get these Lefort fractures as well. The way to really test for this is if you reach up and you grab the maxilla and it moves. If it moves just a little bit, folks, stop, because they more than likely have a Lefort fracture. And you want to just immediately, by the way, I would very, very seriously consider intubating this patient because of airway compromise, especially if there's any signs of bleeding going on with the patient. Now, again, way that you get the facial dislocations or fractures most of the time is a shotgun blast. Again, they can be very gruesome when you first see these. Nasal injuries are usually painful. Swelling usually from a boxer's punch or being punched in the face. Epistaxis is a common problem. Again, stay away from the nasal stuff because we don't want direct cranial oxygenation. The ear injuries is usually you can have the pinna, which is the outside of the ear, actually avulsed. The external ear, they do not heal well, but the internal injuries, it can actually force different pressure changes in the ear, again, causing deafness. Eye injuries, again, want to make sure that you can get small particles in the eye as well as penetrating eye injuries. Corneal abrasions or lacerations can result from this, and hyphema is when you got the blood in the front of the iris and the pupil. Again, this is an example of the laceration to the eye. Again, the good news is the problem is probably going to be the drying out of the eye. Usually the upper lid can close up, but I would probably definitely cover this eye with a moist, sterile dressing. Again, the subcutaneous, you can have bleeding also within the sclera, within the actual, or you can actually have the eye as avulsed. You can actually have it kind of poking or squirting out there. This would be subconjunctival hemorrhage. This is a good example of that. Most of the time they can see out of that, by the way. Again, most of the time. You can also have a depressed eye, enophthalmolysis is what is the pronunciation of that. And again, it's when they squish in and there's soft tissue lacerations around the eye. And if you got a contact lens in there, they can have you can get corneal damage as well from those guys. You can have trauma to the blood vessels of the neck, by the way. Remember, you don't want to restrict the jugular veins. You don't want to restrict the carotid arteries either. And again, the lacerations, make sure that you cover these, especially if you've cut a major vessel. You need to make sure that you cover these guys up. And again, this is only to the soft tissue of the neck. That's the good news, probably. But we want to make sure that we use an occlusive dressing on these guys to make sure that there's no air being sucked into the internal into the venous return. Again, watch out for your airway traumas. And again, it's going to be a major problem. You get vocal cord bruising, and remember, that's only going to make your airway management just 10 times harder. Again, your airway trauma. Again, you can actually dislocate I've seen people actually dislocate their tracheas. It's actually, that is a true medical emergency nightmare because you really can't control the airway at that point. Remember that you can damage the vagus nerve or the esophagus in the neck as well. Okay, your thyroid and your parathyroids are up in that area as well. Cause damage there. Again, they have to do with metabolism, and that could be a long-term problem for the patient. The cervical region, remember, half of all cervical spinal injuries is C1, C2. By the way, that's called a hangman's fracture. When they put the noose around your neck and then drop you, the idea is that you actually break C1, C2, you immediately stop breathing. You don't strangle to death. It actually stops the breathing path from that. So what are we going to do for these patients? We're going to, again, assess the scene, make sure everything's safe. Again, make sure that we do our spinal immobilization and do it in, 3 across. Oy, ojamoy. Guys, I will tell you right now, this is why I'm a huge not fan of the 3 across system. You are not supporting this thorax. You are not supporting it. There needs to be an X across the chest, something across the pelvis, something across the legs, okay? This does not hold jack. Thank you. Off my soapbox. So again, do your ABCs just like normal. Again, you can do it. I don't want you to learn that because I want you to learn this right here. Again, make sure that your airway, breathing, circulation is going good, especially when you got a head injury or a neck injury. You need to make sure that that airway is patent. You need to make sure that your respirations are appropriate, and if they're not appropriate, start fixing that. Okay, start immediately ventilating the patient as needed. Again, below 60 beats per minute, and you got a good strong pulse, at that point I would be suspecting a brain injury, okay? Especially if I've got an elevating blood pressure. All right. Remember to control significant hemorrhage and recognize the signs of brain herniation early. The earlier, the better, okay? The earlier that we get that Cushing's triad identified is we can start helping to treat that. All right. So we did the cups already. We know about that. Let's see here. Secondary exam. This is kind of the normal thing we're going to go through there. Again, make sure that you look at everything, though, especially when you got a head injury, because remember, there's not going to be, you can't see the bleeding usually. If it is little, there's just little bleedings. Look for that Cushing's triad. Look for that elevating blood pressure, that slowing heart rate. If you're dealing with neck trauma, again, remember, if you cut one of them big vessels, believe me when I say you're going to know it because there's going to be blood everywhere, okay? Whether it be the artery or the vein, there's going to be blood everywhere here, okay? Remember, that spinal trauma, if they have decreased sensation, if they have penetrating injuries to the head, neck, spine, torso, these guys get taken to the trauma center. That's an automatic red, okay? Make sure you get your Glasgow Coma score. Know your Glasgow Coma score. Know the correct numbers for that. Again, priapisms is a sign of, is the erection of the male genitalia. And before anybody asks, yes, the girls can get it too, but it's just not the same. So it's because of unopposed parasympathetic stimulation. So what happens is that, yes, it signals that to get bigger. Long and the short of that, though, that's a sign of no control to the area, okay? And that being said, again, that's a good sign that you've got a spinal break, okay? Really good sign, all right? So again, remember to question the patient. Headaches, memory loss, retrograde or anterograde amnesia. They can't remember before the event. They can't remember after the event. Okay. Get your sample. Reassess every 5 minutes. Again, and especially if I see signs of Cushing's triad, I definitely want to do every 5 minutes, because I want to, especially if that blood pressure is sneaking up. That's a big problem for us, okay? Constantly check that Glasgow Coma score, especially when you got a head injury and you start losing numbers in the Glasgow Coma score. You start going in a downward trend. That's, again, obviously not a good thing. Rapid extrication. My little soapbox about rapid extrication. I think that we do it too often. The good news is the thought process has kind of changed about rapid extrication. With me saying that, if you think you got somebody with a spinal break, extricate them appropriately, okay? Now, again, make sure when you're immobilizing somebody, you want to have them in the neutral position. My only sidebar to that is if their head's cocked to one way, it says, I can't move my neck. Immobilize them in the way that you found them, okay? But again, you can run into some problems with doing I can't move my neck. So again, you got to be careful. And there are systems that do spinal clearance, okay, and it's based upon the protocol. What they usually do, if the person's been up walking around and they have no neurological deficit, they might only go with just a C collar only, or maybe just an X collar. And again, the only real true way to do that, this is again the Nexus criteria. Do they have a Glasgow 15? They're not on alcohol or intoxicated. That's the other part of this. Or they have any other distracting injuries? Okay. When in doubt, again, C-spine the patient. But if they don't need it, again, maybe just a C-collar is an effective thing. What we found out is by putting people on long spine boards that we're actually causing more damage than we're doing good. Okay. So again, I think this judicious use of the long spine board in those situations. Okay. Again, we've already talked about the airway and making sure, but again, if we've got messed up structure there, that's when this can cause a major problem. We talked about the blood pressure. Medicines that we might use. Oh yeah. All right. So again, usually controlling seizures is your Valium, your Ativan, and again, they have the thing that they like about the Ativan is it's got a shorter half-life, and I'm going to tell you though. I mean, some people swear by it. It's good for calming people down, not necessarily good for, actually a seizure type incident. It does work for seizures, but I found that Valium is a lot more effective. Your morphine, again, remember that it's to relieve pain. The good news about the Valium and the Versed and the Ativans, they just forget that they're having pain. Fentanyl is, again, another one for controlling pain. Remember that they are going to have pain, even though, again, they can still have pain. Ketamine, wonderful drug. Again, it's especially when you got a low blood pressure. If you've got a head injury, guys, I would probably not go with the ketamine. Okay. Again, using care with those. Mannitol is an osmotic diuretic. There's still some systems that use that, and the idea is that it reduces the intracranial pressure by drawing fluid off of the brain. Dextrose, again, small doses of head injury to prevent hyperglycemia. However, I'm gonna temper that with, if you do have a brain bleed, probably dextrose is the worst thing that you can give, because sugar water going into bleeding space is usually really bad, especially if it's bleeding space with brain tissue. The regular use of steroids, they used to hit them with a whole bunch of, like, nearly a gram of solumedrol. 1 to 3 grams of solumedrol for a head injury patient. They've gone against that now. They said that's a really bad idea. Let's not do it. And the patient doesn't improve with 1 or 2 fluid challenges, consider a vasopressor, especially if you've got a known neurological break there. Okay. Again, usually we don't have to give guys with head injuries fluid challenges. So if you've got a patient with a head injury that's got a low blood pressure, start looking for other causes, okay? You've missed something, okay? Yes, can they be in neurologic shock? Can they be in a neurogenic shock? Technically, yes. However, look for the other things that might be causing them, okay? Combative patients, fentanyl or benzos work great. fentanyl and benzos together work even better. Okay, and again, just make sure that you have, and I think you guys do have a protocol here locally in which to use that. Again, judicious use of that, please. Again, remember you can use red lights, and one of the problems they say that if you do have a head injury is that you can cause a seizure because of the strobe lights. Most nowadays, gang, the strobe lights are directed to where patients can't see them in the back. If they're transported by air, you really need to make sure they're secured to the spine board, and again, and the airway should be protected by the endotracheal intubation. Remember, especially if they or know what's going on, especially like in a spinal break situation. Remember to talk to these people. Keep talking to them. If they've got head injuries, they can get distressed, confused, combative. Do not take this behavior personally. Okay. Now, again, it's very unfortunate about trauma with the head because, again, a lot of things can go wrong. Again, there's kind of like two separate divisions. It's the one with the pressures going up and they're losing control functions. The other one is when the cord's cut and they lose the ability of control. And so you got to make sure that you get which one that you're dealing with and then deal appropriately with them. Again, neurogenic shocks, we usually give them a couple fluid challenges. And again, if they're a head injury, we kind of want to stay away from the fluid challenges. Normal saline does not help a head injury, okay? So keep those little factors in mind as you're dealing with this. All right, that's going to do it. I will see you guys.